And I'm first going to hand over to Liz Chidgey on my left, who is the Managing Director of Essex Cares.
Thank you. I just want to, actually I'll sit down. Okay. I just want to introduce the session to you. As said, I'm Liz Chidgey, I'm the Managing Director of Essex Cares, and we're going to hear today from Zara Nightingale, colleague, who is Head of Regaining Independence Service, but also the overall Head of Reablement Service within Essex Cares, but also Julian Wall, who is Head of Reablement in Essex, and I'll just explain a bit more about that. As said, what we want to look at today is some very practical learning outcomes we have around reablement. So really giving you an understanding of what we think some of the multiple benefits of reablement is. Just having an industry overview about how it can, as an input, actually have very successful outcomes when you're starting to look at integration and how we integrate across health, social care, and with other services within the community. Looking at current pathways, in other words, what's the learning to date? We've been doing reablement for about 3 years now, and as you know, it doesn't necessarily have universal coverage across the country yet, but also how these might change in the future. And a review about our holistic and seamless approach, and giving you some case studies whereby we can just hear the voice of the people we've been working with. So just to give you some context around Essex Cares, we were one of the first local authority trading companies, and we were set up by Essex County Council in 2009. And whilst we are a private limited company, our shareholders are the local authority. And we provide a whole diverse portfolio of services, which includes 5 big contracts in Essex for reablement, and we are expected to have about 7,500 starts this year just in Essex alone. And we also manage a contract in West Sussex. But apart from that, we have our real focus is around prevention and early intervention. So we have an integrated equipment service with our health colleagues in Essex, wellbeing and activity centres, which look at a whole range of options for people 18 plus into older age. Work-based training sites, particularly for working age adults, and that includes employment services. Outreach and home share services, sensory and home safe, which is a virtual service where we are developing pathways, particularly for citizens who don't necessarily come through the health and social care system. And as I say, we are very committed to delivering outstanding customer services. So what we want to do is first hear from Zara about the whole concept of reablement and how we have thought about and practiced that within Essex Cares, and then go on. Julian is then going to take us through some case studies. So Zara.
Hello everybody. I hope it's going to be helpful for me to explain very simply what reablement is. In a nutshell, it's free, which is very positive for our customers. It's a service that lasts up to 6 weeks, and I'm always very clear about that up to 6 weeks service. I think sometimes people think it's a 6-week solution whilst ongoing support is commissioned, but truly effective reablement can take place within 2 or 4 weeks. It's a service for people aged 18 or over, although I think if you look at the stats coming through, predominantly reablement at the moment is being used for our older population. It is available to people to try and support them to retain and regain independent living skills. There are lots of different suggestions as what reablement is, but I think the principles are that we're trying to support people who through illness or age have lost confidence or independent living skills, and the whole process is about working with the individual to identify independent living strategies that can ensure that they go on to live independent, happily and safely in their own homes. Okay. In terms of customer benefits, I think I'm so passionate about the service, I could probably spend all day telling you how wonderful Reablement is. The integrated living strategies that should be the golden thread throughout Reablement are very personal to that individual. A very good Reablement programme starts when you get it right on the ward. If you're going to discharge people into Reablement from hospital, a ward-based assessment where everybody in the hospital understands Reablement and is working with that Reablement service can achieve some very positive outcomes. Where you have staff in hospitals talking about you're going home with the carers and they'll sort that out for you, you've already started a mindset which isn't reabling. So it is very important in our experience that you have ward-led discharge and that you have a holistic approach from the professionals who are referring into Reablement, setting the scene for what is very much a service that is enabling. It's not time and task. It's not carers going in 3 times a day to do things for people. It's about a group of people working collectively to support individuals to identify goals, and those goals are set to outcomes. Those are our professional words. For the customer, it's about saying what matters to you, what do you want to do when you get home, what's important to you, and making sure that you have a realistic and measurable programme that enables the individual on a daily basis to reach those goals. It's very intense, it's only for 6 weeks, and yet you can be going in to support people in attaining goals 7 days a week, as I say, for up to 6 weeks, sometimes only for 2 weeks. It does prevent the deterioration of dependency, and it really ensures that the well-being of the individual is met when you have a programme that everybody works to. Early intervention and prevention for vulnerable people is key to making sure that the right people are selected for Reablement, and that's why generally, although there is a very wide criteria for who can come into Reablement, it's not always suitable for people at end of life or those people who have later onset dementia and who don't have the potential to follow a programme of Reablement. So what are the organisational benefits as well as the benefits to the individual? There's often many cost savings to the local authority. When you choose people and identify on the ward this person's suitable for Reablement, and you follow through a programme of Reablement that truly enables somebody to become more independent, gain their confidence, feel better and well at home, they've identified strategies for safer living, then potentially they're not going to need ongoing care. At best, people leave Reablement without any need for domiciliary support and can continue to be independent at home, research shows, for over 2 years. We can also support people so that although they have ongoing care needs, those care needs are reduced because they're doing more for themselves. In terms of administrative savings, the Essex Cares model that we've developed over the past 3 years has enabled the local authority to hand over more responsibility to Essex Cares for the whole assessment and review process. 3 years ago, when we provided Reablement services on behalf of Essex County Council, the initial assessment was completed on the ward by the hospital social work team, and we received the referral. 3 years later, we have ward-led discharge where our staff, Essex Cares staff, go onto the ward, complete the assessment with the customer, explain the service to the customer and their family, and then we work with that individual to reach their desired goals. And then we gather information on behalf of the customer, which supports the review process. All of those cost savings for the local authority mean that they have less involvement with the customer, which is appropriate. And I always think from a customer focus, it's also better for the customer because they're not having to share their story with lots of different people. But it also means that where there are customers who have complex needs and are arising from before they came into Reablement, or sometimes during, because we're talking about older people on a frailty pathway at times, it frees up the social work teams to review and support those people with complex needs, whilst Essex Cares supports people at the lower end. In terms of cost savings to health, if somebody is assessed on the ward and has a holistic reablement programme, which includes the provision of assistive technology and equipment, when people get home in a planned way because they've had a ward-based assessment, they're less likely to return back the next day. I know multiple customers who in the early days would be discharged at home, equipment's not in place, meds are not in place, discharged late at night, back in hospital the next day. When you have professionals coming together in a multidisciplinary way and making sure that people are discharged at the right time of day, their equipment is in place, their needs are understood, and they go home and the reablement service starts on the day that somebody goes home, they are far less likely to return to hospital. It also supports and promotes the swift discharge from hospital because our staff are in that hospital ensuring that the customer is going home and that plans have been made for them to have somebody meet them at the door. Thanks. What is the supporting evidence? Unfortunately, there's limited research at the moment into reablement. I think that's partly because it's a new service. There are emerging models, but they all vary in their approach. Essex Cares are very lucky because we have a contract, as Liz said, in West Sussex and in Essex, and we're now going to be able to look at how two different models work and hopefully take best practice from both. And I know we're very keen to look at how we can do some research on the services we provide. What research is out there has been commissioned by the Social Policy Research Unit via the University of York. And what they've found is that people who had domiciliary support before they came into reablement, on exit from reablement, over 21% of customers were able to manage their own personal hygiene, personal care needs, and over 19% of people were able to dress and undress. So there's real value in looking at reablement, not just from when people are discharged in hospital, but also when they're in the community and they may have already started to acquire dependence while receiving home care, but reablement can revisit those needs. It is also used very successfully in West Sussex to look at reducing people who need double-handed care to single-handed care using the doing with and not for approach. Research has shown that people who benefit from intense reablement support and exit the service with no ongoing care needs, between 36 and 48% of people at 2 years continue to be self-caring and independent at home. Now, if you think of how much it would have cost to provide that support within a 2-year period for people who just go straight through to the home care model, you can see there are significant savings for local authorities and health for people who go into reablement. More importantly, as I've said, my focus is always customers. The increased sense of confidence and well-being for people who receive reablement can't be neglected. It's a very positive outcome for people, and that's what we hear all the time. Not just the customer, but their families say, we're really pleased that you've worked with us. I've tried to get Dad to do this and he just won't do it, but your staff have suggested it, and he's now listening to you. Equally, we see lots of customers where family members say, oh, Mum can't do that and Dad can't do that. But when you have that third-party reablement worker working empathically with families and working to an agreed reablement programme, you see a real change in how families relate to and acknowledge that their parents and their brothers and sisters and partners are actually more capable, given the support and different strategies for tackling independent living, than they may have assumed on discharge. So how is this working at Essex Cares? As Liz had already mentioned, last year we provided support to 5,500 people. This year we're looking at providing support just in Essex alone to over 7,000 customers. Just this year alone, our stats have shown that 81% of the people that came into our reablement services were self-caring at discharge. And by self-caring, I mean that they weren't dependent upon local authority support at the end of their reablement programme. I nearly said their 6 weeks programme. Lots of those people had less than 6 weeks support. In doing this, we've been able to identify significant savings for the local authority, and as I think I've already mentioned, the benefits to self-caring for the individual, their carers and families can't be underestimated. In recognition of how Essex Cares are working to improve people's perceived sense of health and well-being, and also in recognition of how, if you can refer directly into reablement, you can create savings for the health economy, the clinical commissioning care groups in Essex are investing with Essex County Council jointly into reablement. And we have a model whereby any health professional can refer directly into reablement. There's no third-party handoffs, there's no duplicate of assessment. A GP or a community matron can make a direct referral into our service, and we can provide that service from the following day. It also supports hospital admissions avoidance because our service is a 24-hour response service. This is very much an integrated approach with our health partners, and it's something that we continuously seek to evolve and develop. So what does the future hold? I think from an industry perspective, we need to create a fully integrated care pathway and services. What I'd really like to see is a holistic assessment, and one that is a journey for the customer and follows through with the customer. If we're going to continue working as well as we do with our health colleagues, it's very important that all the players, all our professional colleagues and our multidisciplinary teams understand the service specification. We're a provider and we're contracted to provide a service, but it's very important that the Commissioner shares and that we share with all of those multidisciplinary organisations what's in our service specification so that everyone understands what the reablement offer is for that customer. Joined up working is key with social care and health. Reablement can start from the ward-led discharge, or it can start at a later stage in the customer's pathway. Some customers are receiving support via early stroke discharge pathways and can then benefit from a later stage of reablement. But again, that common assessment, that understanding of what happens before or after a professional group are involved in somebody's support is very important. It's also important that we mention the voluntary sector and communities, because I've always think of the ripple effect. When you throw a pebble in a pond, it ripples. When you start to look at independent living strategies for customers, there are ripples. We're there to do with and enable. We're not there to do everything for the customer. So those ripples are about trying to support people to understand what services are available to them so that they can make use of the services going forward. We're very much an outcome-based delivery model, and those outcomes need to be set before the customer leaves hospital or the minute that somebody decides that from the community somebody will benefit from a reablement programme. Okay. The holistic approach. I hope my banging drum is getting louder and louder. It's really important that reablement is a whole service provision. We're working very flexibly to meet demand, as we've mentioned, from 5,000 to 7,000 starts in a year. It means that our services are growing rapidly and demand grows rapidly. And we need to work continuously with our commissioners and partners to improve these services. And we're very fortunate that in West Sussex and Essex, we sit round the table with our commissioners. It's not them and us, it's us, and we're all in this together. And I think as a new concept, it is important that CCGs, health, community services, anybody involved in supporting the citizen to live well at home needs to come together to decide how to develop those services. And last but not least, the one key person that needs to sit round the table is the user of that service. That's when we'll get full integration and a model that really works for the user. We've been very busy building pathways that offer a seamless approach. So as I mentioned earlier, we provide the assessment on the ward where relevant, And we also gather information on behalf of the local authorities to support the review process. Who better to support the review process than the people who've been working with somebody for 2, 4 or 6 weeks? It works well, the local authority is happy. I used to work for a local authority and I did some work around reviews, and I thoroughly understand the pressures and the difficulties in getting out and reviewing people on time. You tell your local authority you're going to take some of that work away from them, and they're only too happy. We're also building relationships with health providers of community services, including telehealth, physiotherapy and community nursing. It's very important that the Reablement Independent Living Strategy programme that you develop looks at who else is involved with the support of that individual, and that you all work together in a common way to achieve those outcomes. It really isn't helpful if you've got one organisation going in to support somebody who's had a stroke to do their buttons up on a cardigan using a hook, and then have a care worker come in and say, oh, they're a bit fiddly, Mr. Smith, I'll do them for you. We all need to work together to understand the goals and the outcomes. Our service offerings signposts and provides guidance. Within our multidisciplinary team, we have registered managers, because our service is registered with the Care Quality Commission. We have social work input. We have nurses from the North Essex Partnership Foundation Trust working alongside us. And this year, in recognition of the holistic requirement to support people at home, we've employed and seconded to our service Age UK information advice and guidance officers, because we all know that if you're looking at trying to encourage and motivate people to work to a reablement programme or any programme, if they've got debt issues or housing issues, that's going to take their focus away from being able to feel encouraged and positive about what you're trying to do. And our Age UK workers work with our customers not just up to the 6-week point, but they will provide support and advice and guidance to our customers up to 91 days, because within our contract with Essex, outcomes are measured not just at the exit point, but also to see how people are doing 91 days after they started their service with us. So this is the pathway that we've developed. As I say, it's moved on very much from the days when the assessment was completed by one person, the customer was referred in to us, provided with reablement, and then reviewed by a third person, and provided ongoing support perhaps by a fourth person. Now we have direct referral from GPs, community nursing, out-of-hours support from social care service teams and social care themselves. We also have acute ward-led discharge reablement. Once the customer is accepted into our service, within 24 hours, they are seen by a lady in a van. Not Alan Bennett's lady in the van, but a professional support worker from Essex Cares who actually has equipment on that van. We all know it happens. The equipment's been ordered by the hospital, someone's ready for discharge, you're told when the customer gets home the raised toilet seat will be there, and it's not. The consequences of that could be a fall, a broken hip, a readmission. Because we have that integrated equipment service within Essex Cares, we're able to go out, and if equipment's not there, it's not a problem, or if something's been forgotten because there isn't always a home visit at the point of decision making around discharge from the ward base, then we can provide that other piece of equipment to ensure that people can start to be reabled from day one within those first 24 hours. We're very clear about understanding what reablement is to the customer, their families and their carers. It can be frustrating at times when family members say, I don't want mum to do that, or they can't do this. And we do need to work with families and carers to make sure that everyone who's living in the household is signed up to the reablement programme. We complete equipment, risk assessments and environmental assessments. Between day 2 and 2 weeks, we start to review the programme. Because it's an intense programme, the review of how customers progress, how goals are being attained, how outcomes are being met, need to be a daily process. Some people after 2 weeks may be referred for community health support, or they may leave our service. Between 2 weeks and 4 weeks, again, we will continuously review, and we might need to pass people on to social care for a complex review. Not everybody who comes into reablement is able to be fully reabled, but as I said earlier, 81% in Essex are. And for those people who need some information and advice, this is the point at which we may refer them on to our own Age UK advisor, or to signpost them on to other support services within the community. Between weeks 4 and 6, we're always aiming to reduce the number of times we go in to support somebody, and reduce, as people attain goals, the levels of support that we provide, so that somebody is fully independent and leaving the service without any ongoing care needs. If ongoing care needs exist, as sometimes they do, then we will support the review process on behalf of the local authority, so that ongoing care is commissioned in a timely manner. All right. I'm now going to pass you on to my colleague Julian, who will give you some more information about how this is working in a very practical rather than theoretical way.
I think my time's running out. We've heard from Zara, thank you. What is reablement and what are the benefits? The proof is in the pudding, as it were. What is the customer's experience? The slide shows some comments that were collected during a recent survey within Essex Cares. I'm running a bit short on time, so I'm going to skip to the case studies. We've got Sheila first. She'd been admitted to hospital for an elective right hip, total hip replacement. She lived with her husband, who had a diagnosis of dementia. She was his main carer. She didn't have any support from the local authority in the way of a social care package. Her goals were she wanted to be independent within the 6-week period, with washing, dressing, undressing, hair care, showering, increasing her mobility. She wanted to be able to access the stairs to enable her to sleep upstairs, as she'd elected to sleep downstairs for a time. And she wanted to access a local community again. You can see that she, after the initial visit, she was observed to be able to complete certain tasks slowly but safely, and she'd elected to sleep downstairs. She was mobilising with a walking frame initially. She was independent with her medication. She arranged some repeat prescriptions. What she needed support with was some support with doing some shopping initially. She'd been previously independent with accessing the community, so we needed to look at that. Her reablement programme started with minimal support with personal care, with her lower half. She was okay with the top half, and some meal preparation because of walking with the frame and just being discharged. We supported her to complete her goals with the assistance of one support worker. They demonstrated different techniques with small pieces of equipment, long-handled sponge, a bit of a helping hand, and verbal prompts to build her confidence. We held regular feedback meetings where support workers were able to feed back on the progress, and Sheila was making really good progress. She was very motivated, so we were able to gradually reduce down her input. She declined support for her husband, as she wished to be able to support him without any further external intervention. We offered her some advice from the Age UK worker who went in. Although she declined, they did leave her with some information that she could use at a further stage. At the 91-day call, she was accessing the community, and as you can see from the slide, she was also going along to a local amateur dramatics club, although she was saying that she was offered sort of parts with older people and animals, but nevertheless she was still going along, and she was able to access the community with her husband. The next one is Gordon with some memory loss, and the staff worked closely with Gordon to come up with some strategies. I'm going to whiz through this one really quickly. There was issues around him preparing and eating his meals, forgetting to take his medication and using the gas appliance. So the worker worked with him and we looked at a piece of equipment around the medication dispenser, disconnected the gas because he was unsafe to use, and then we looked at alternatives such as a microwave and toaster and put some instructions, prompts for him to use because he had some memory loss. The outcome after the 6-week programme was that Gordon was able to, although his preferred area for personal care, he used the perching stool in his kitchen, which that was fine, he managed to deal with that. The telecare dispenser, pill dispenser, was working and prompting him to take his medication. The family were able to assist with his showering by using the long-handled aid, and the gas, and he was able to use the microwave with some prompts and the toaster. And he was self-caring at the 6-week stage and was able to access the community and socialise he had done prior to his admission into hospital. I'm going to hand, that was really quick. I'm going to hand back to Liz.
I mean, hopefully you've had an overview around both current service, but also some thinking about where we need to be focusing into the future. And just open it for any questions. I recognise it's lunchtime. If there are any questions within the forum, if not, we're happy to stay after the end of the formal session if people have got some individual things they would want to ask of us.
Front. You got the microphone? I think it's time. There you are. Completely blinded. I hope you're okay there, Liz.
Yeah, that's fine.
I'm David Hogarth from Westminster Health Watch. I've seen Reablement in action a bit, and particularly it does involve home carers. I don't know whether it does with you, but it does. And I must say that my anecdotal experience is that the home carers were no different from the ordinary home carers that people were getting, that they were, frankly, not doing really any reabling at all. So I wonder if, the success, Westminster has quite a good success rate, whether that is entirely due to the OTs or whether you have some special way of getting the home carers to do a better job than we do.
I think Julian and I looked at each other and nodded and said, it's the training. It's the training, and the multidisciplinary approach. It's about being able to have social workers and OTs sitting in on weekly feedback meetings, not just for the weekly feedback meetings, but so you can ring into the office and say, can I just speak to the OT about this lady? Or can I speak to the social worker about this issue? And having that professional support, which I think differs in traditional home care models. I don't think those levels of additional professional support are available. We do have a very rigorous training programme. And the other key is the Reablement programme. Everyone needs to be signed up to it and following it. It's a living daily document, needs to be reviewed daily. Does that answer your question? Oh,
I think it's a very good question, and I think it's one that's quite difficult to have a definitive answer on it. A lot of it is about culture, about moving away from doing for people to actually self-management and people taking on. So the responsibilities aren't just with the carers, they're also with the family, the individual who's part of it. And I think the research that's going on, particularly as we move to much more integrated service, will start to give an evidence base to potentially what works, what inputs work, and how we might need to shift and shape in the future. But I don't think you can give a definitive answer at the moment.